Hello. So today I'm going to describe some of the research that I have published on my postdoctoral fellowship. My PTBi main project is still ongoing, so I'll describe that a bit. And I only have a little bit of time, so I'm just going to give brief snapshots of this work. Okay, so my core focus is on perinatal depression and the problem of perinatal depression. We know that this is unfortunately, a really prevalent problem. 1 in 8 women become depressed during the perinatal period, and a shocking 7 in 10 depressed perinatal women do not get treatment. And of course, we know there are negative correlates and consequences, not just for women, but for their families and for their relationships and for society. And so for me, as a clinical psychologist, what is most exciting about this is the fact that interventions that are effective and accessible may have benefits that extend beyond just the individual woman. So before diving into my data, I wanted to provide just an overarching framework that guides my research. So at the core of this is the problem of perinatal depression. And in my recent work, I have examined consequences such as birth outcomes and healthcare utilization. I've also studied interventions to reduce depressive symptoms. And what I am especially passionate about is prevention programs that may altogether prevent perinatal depression and therefore avert its negative consequences. So to this end, I've evaluated prevention programs that are designed specifically to target the factors that place women at risk for becoming depressed during the perinatal period, such as a history of depression and poor sleep or insomnia. And then finally, because these prevention programs and intervention programs are irrelevant unless we can get them into the hands of the women who need them, I'm also really excited about studying ways to increase women's access to these programs using novel delivery formats. So my work has focused on digital interventions, integrated interventions, and co-located interventions. Okay, so starting with consequences of and interventions for perinatal depression. So research has shown that prenatal mindfulness-based interventions are associated with reductions in perinatal depressive symptoms, but it's unknown whether these effects are sustained beyond 6 months postpartum. None of the existing research has followed women beyond 6 months postpartum. So we recently studied this in Alyssa Eppel's MAMA's study and in Nikki Bush's SEED study. The MAMA study recruited pregnant women who were predominantly low income and racial or ethnic minorities and overweight or obese. And participants received either treatment as usual or a prenatal mindfulness-based intervention that focused on stress reduction, improved nutrition, and mindful eating. And then the SEED study followed these women and their babies through the first few years of their babies' lives. So consistent with, so we used, in this analysis, we used a latent class analysis to identify empirically defined profiles of depressive symptom severity from the end of pregnancy through 18 months postpartum. And consistent with prior work, we found that perinatal depression was heterogeneous. So in this sample, perinatal depression was best characterized by 3 classes of depressive symptom severity. So women who had none to mild symptoms, women who had none to minimal symptoms, mild symptoms, or moderate symptoms. And interestingly, you can see here that depressive symptoms remained fairly stable from the end of pregnancy through 18 months postpartum. But most interestingly, we found that participants who received prenatal mindfulness training had significantly lower odds of being in this moderate severity class compared to women who received usual care. So this suggests that prenatal mindfulness training may have benefits that last as long as 18 months postpartum, which is encouraging because maternal depression has negative consequences beyond just the perinatal period. Okay, and then also recently, in a paper led by Danielle Rubinov, we also investigated the association between perinatal depression and infant health care utilization. So we know from previous work that mothers with depression have higher healthcare utilization, higher rates of healthcare utilization, which contributes to the substantial economic burden of depression. And so we predicted that this would extend to infant healthcare utilization. And we were curious whether prenatal mindfulness training would attenuate this association. And sure enough, we found that among mothers who were in that class I just showed you of moderate depressive symptoms, infants of women who received usual care had an average of 15 healthcare visits in the first year of life, which is about twice what is recommended by the American Academy of Pediatrics, compared to approximately 8 among women who received prenatal mindfulness training. And it was estimated that prenatal mindfulness training saved approximately $473 per child in the first year of their infant's life. Okay, so now switching gears to another important consequence that I know is near and dear to our hearts, preterm birth. So we know numerous studies have shown that prenatal depression is associated with increased risk for preterm birth among adults, but it was unknown to what extent this is also true for pregnant adolescents. So we recently examined this in Jeanette Ikovich's cluster randomized controlled trial, where she compared group prenatal care to individual prenatal care. And we found that elevated depressive symptoms were highly prevalent in this sample. 50% of pregnant adolescents scored above the cutoff at baseline in the second trimester of pregnancy. And sure enough, third trimester depressive symptoms were associated with significantly increased risk of preterm birth. So, for example, a participant who scored 1 standard deviation above the mean on depressive symptoms had a 30% increase in the odds of preterm birth. In this same sample, we found that group prenatal care participants experienced significantly greater reductions in depressive symptoms through 1 year postpartum compared to participants who received individual prenatal care. But you can see we found that those differences were evident primarily in the postpartum period. So I think there's definitely room within group prenatal care to really maximize its benefits on prenatal depression and to place more of an emphasis on that. But I think to me this is an ideal approach for reducing depressive symptoms because it integrates that within routine prenatal care rather than requiring women to go to additional visits or additional appointments. Okay, so now switching gears to risk factors and prevention strategies. So we know that a prior history of depression is one of the most robust risk factors for perinatal depression. So 30% of women who have had a history of depression will become depressed during pregnancy or postpartum. But fortunately, mindfulness-based cognitive therapy was designed specifically to target the cognitive vulnerability among people who have histories of depression, and it has a substantial evidence base among non-perinatal individuals. And at University of Colorado, our research team adapted mindfulness-based cognitive therapy specifically for use during pregnancy, and we found it was feasible and acceptable. And then subsequently, in a randomized control trial, we found that women who were randomized, so these are women who are not currently depressed, but they have histories of depression and therefore are at high risk for becoming depressed during pregnancy or postpartum. We found that 50% of women randomized to usual care became depressed, either in pregnancy or by 6 months postpartum, compared to less than 20% of women who received mindfulness-based cognitive therapy. At the same time, we learned that there were a lot of practical barriers to attending weekly intervention sessions, such as scheduling conflicts, difficulty finding transportation, and more broadly, there is a relative paucity of clinicians who are trained to provide this treatment in the first place. So in order to increase access to this program, our team developed a digital adaptation called Mindful Mood Balance. And initially we studied it and found it effective among men and women who were at risk for depression. And then in my dissertation, I led a multi-site extension of this work to pregnant women and found that it was credible and acceptable. But over the course of this work, one of the things that I became aware of is that depression is a really hard word for perinatal women. And I think that this issue is really underscored when we look at images from our culture. So I think we see really extreme depictions, right? So like on the one hand, women are expected to be happy and glowing with perfect hair and makeup, even though they are 8 months pregnant and have 2 young children. Or on the other end of the spectrum in terms of mood, women who experience depression are thought to be dangerous and bad. Although my work has shown that the public does not actually view depressed pregnant women negatively, pregnant women, perinatal women report that fear of stigma is one of the main barriers that they don't reach out for care. And my work has also shown that women with histories of depression are especially self-critical. So this has led me to wonder whether there are other inroads to preventing perinatal depression. And in my work, one thing that pregnant women frequently complained about was just the difficulty of getting good quality sleep. And so many of the women that I have worked with pinpointed the beginning of their depressive symptoms with the changes in sleep that come during pregnancy. So we have, sure enough, found in the mama sample, this is the same sample I described earlier, 63% of pregnant women had poor sleep quality at baseline, which predicted increases in depressive symptoms over the course of pregnancy. And as a result of my postdoc research, I have become more and more interested in sleep as an important target in and of its own right, over and above its contributions to perinatal depression. So for example, with Larry and Laura and Rebecca and Eric, we recently looked at a diagnosis of sleep disorder during pregnancy and risk for preterm birth. This was drawn from a cohort of nearly 3 million women, and we compared women with a diagnosed sleep disorder to matched controls. And I'm only going to present a little slice of our findings, but if you're interested, you can learn more next month when our paper comes out and at my collaboratory on August 24th. But so just a little slice of the findings. So one thing that we found was that women who had a diagnosis of insomnia during pregnancy were at almost twofold higher risk for delivering before 34 weeks gestation. But it's unknown right now to what extent insomnia is addressed during pregnancy in usual care. So that's something that we're trying to find out. We're currently recruiting pregnant women to participate just in a 10-minute online survey to help us characterize usual care. So specifically what we're interested in is, are prenatal care providers routinely asking women about their sleep? Is insomnia going undetected or undetected? What treatment recommendations are providers making? And what types of treatments do patients actually utilize? Okay, so cognitive behavior therapy for insomnia, it's now recommended as the first line of approach to treating insomnia. It's effective among non-pregnant patients, but there are no published randomized clinical trials investigating its efficacy among pregnant women. And further, there is a care gap. So for example, there's 0 CBTi providers in Fresno and 3 in Oakland. But there have been recent advances in digital delivery formats that may help bridge this care gap. So one example is Sleepio. It's a digital adaptation of cognitive behavior therapy for insomnia. And so in my PTBi main fellowship project, I am currently recruiting participants for the Research on Expecting Moms and Sleep Therapy study, the REST study. And we are testing whether pregnant women with insomnia who are randomized to receive digital CBTi will show improved insomnia symptoms compared to those who receive usual care. And then we're also secondarily exploring the impact on birth outcomes and on depressive symptoms. I also feel strongly that interventions are needed for pregnant women who have poor sleep quality that doesn't meet the threshold of clinical insomnia. So to this end, like Miriam mentioned, I am working with the investigators on the GLOW trial, which is the group prenatal care project in Fresno, to add in some curriculum to discuss with women the normal changes in sleep that happen during pregnancy and to provide tips for healthy sleep. And then I also recently submitted my K23 award to optimize and evaluate a mindfulness-based intervention for poor sleep during pregnancy. My hypothesis is that mindfulness-based interventions may be particularly helpful in helping women cope with pregnancy-related physical symptoms such as pain and discomfort. So like I mentioned, if you're interested in this topic, please come to my collaboratory next month. I think it's going to be a really exciting and engaging conversation. Okay, so to wrap up, we were asked to reflect a little bit on how this postdoc has impacted us and what we've learned. And so I was thinking back to who I was when I started this position. And if we go back to my initial framework, this is really who I was at the start compared to where I am now. And I feel like my research has just been enriched in so many ways, not just in these content areas, but also methodologically and statistically. It's really changed how I frame my questions, how I think about these problems, and most importantly, it has been, I think I have benefited the most from the opportunity to learn from and to collaborate from so many leaders in their respective areas. So on that note, I wanted to just express my deep gratitude to all my mentors and collaborators and to the REST study staff. And you know it's a good sign when you can't fit all your thank yous on one slide. Just a thank you as well to the Preterm Birth Initiative for funding me and this work, and to the Health Psychology T32, who also funded part of my postdoc. That's it.